I shall be, first of all, talking about how to customize the procedure according to what kind of patient you have. And I have no financial interest. So, choice of refractive surgery in any patient depends on the age of that patient, on the lifestyle of that patient, type of refractive error the patient has, and the type of corneal topography that is reflected. So, we know that these are the basic factors, and of course, there's a range for each one of them. Now, within that normal range, and with after excluding all other ocular morbidities, and systemic morbidities, we have to choose the right patient, and that is what I'm going to talk about. So we are not talking about, glaucomatous eyes or eyes with early cataract or anything of that sort, just normal eyes in normal patients. Now, if you have a young patient who wants refractive surgery for an occupational purpose, like, joining the forces, or maybe the requirement for some, jobs that require extremely good vision or good binocular vision. So in such cases, when the refractive error is very low, it may be advisable to go for LASIK and sometimes trans-PRK rather than a more invasive procedure like SMILE or maybe phakic intraocular lenses. Now, if it is low to moderate in the range, so now the first one was in the range of 0.25, 0.5 or a 0.5 cylinder, which does not give the patient a refractive, a visual acuity of 6/6, but is somewhere in the range of 6/9. And this is a deterrent for a very critically, selected occupation. Then such kind of a procedure may be optimal. But of course, you'll counsel the patient to the effect that there is always a chance of overcorrection, undercorrection, and so on. Now, if you're dealing with a low to moderate patient, so here we are talking about someone who has some myopia in the range of, let's say, -2 or some astigmatism, then laser vision correction as well as phakic IOL, depending on what the topography maps show, is the ideal procedure. If you're talking about a high myope or a very high hypermetrope that does not come within the purview of LASIK, one, or they have corneal indications which prevent you from doing any form of laser vision correction, then phakic IOLs and bioptics. So phakic IOLs or IOLs combined with top-up laser or maybe a refractive lens, something above 35 to the tune of anywhere around 50, 55, so long as there are no other comorbidities. First of all, if you're doing a pure distance vision correction, it's very important to counsel the patient that they are going to develop presbyopia, because most myopes in this age range, they don't like wearing, bifocal glasses. They always keep their single vision glasses on, and they lift their glasses to see near. So these are patients who are going to be shocked the next day when they find out that they're not able to read near, not able to see the grains in their food, or, put a bindi on their head and all that. So it's very important that you counsel them that presbyopia is going to, have an onset the very next day after laser vision correction. Now, in case the candidate is suitable for a blended procedure like Presby Max or Pres Beyond, where you use aberrations, or where you use increase the depth of focus, so such corrections can also be applied. Again, that depends on the indication. And of course, in the offing is the presbyopic IOL, phakic IOL by EVO, called EVO Viva. So when that comes to India, we can, I hope it provides a lot of relief to us. Then of course, refractive lens exchange is also a very good option in such patients, especially over the age of 40, even if there is no cataract. Again, you have to make sure that the posterior segment is pristine, there's no pathology that you have to deal with there, and that's very important in such patients. Now again, the lifestyle, depending on whether you are into combat, like one of the forces, or whether you're into contact sports, you might need to choose a flapless procedure like SMILE or trans-PRK, maybe ICL, though I may not be too much in favor of it, because anyway you've created an incision. If you have a chance of high UV exposure, for example in surfers or in yachters, those that go out in the sea and might not be able to wear a UV protection all the time, it may be better to avoid a PRK, a surface procedure, because the chances of developing fibrosis and regression are much higher, and you can go for a flap-based procedure like LASIK, or a flapless one like SMILE, or even a phakic intraocular lenses. So this is how you customize it depending on what situation the patient is in. Then of course you have conventional choices for the type of refractive error, as we have been taught all along, that when you have a myopia that is anywhere higher than -6, you can choose a trans PRK with MMC, but less than that you can avoid something with MMC. But right now I use MMC for all refractive errors with trans PRK, because I've seen that even astigmatism as low as 2 or 2.5 can lead to subepithelial fibrosis. Now any high range refractive error to prevent an oblate cornea, it may be better to go in for a phakic intraocular lens. And in high hypermetropes, which don't come in the purview of laser vision correction by way of topography or by way of the magnitude of the power, can go in for refractive lens exchange or a phakic intraocular lens. Now the most important part is the wetting of the topography. So if you see something obvious like this, where you have a very steep anterior and posterior cornea with a low pachymetry, then it's a strict no. You have a skewing of the axis or a superior inferior asymmetry, you have an obvious cone, it's a strict no. But then you would have certain patients that are somewhere in the borderline, and you may need to decide whether to go in for laser vision correction or phakic IOL, or maybe sometimes neither. So here you can see that there is a patient who has high astigmatism. This is someone with 5.5 diopters at 180 degree. You can see that the cornea is relatively okay. So it is 469 over here. And now this patient, I have put a limit of 470 microns for all my laser vision correction patients. So in case I do an astigmatic treatment, maybe the cornea will bear it. I don't think there'll be much of a problem. But still, I would not do it, because there is a point where you have to say no, and if you keep either 460 or 470 or 500, whatever your correction, I'd suggest not to go below 470. Then you should say no, however small the correction is. So with a good AC depth of 3.65 and a large white to white, you can see the topmost number 12.9. So this patient is an ideal candidate for an ICL. Now coming here, you have a high hypermetrope plus 9 diopters, and you can see that the cornea is very steep. So there is no question of doing a laser vision correction here, because you're going to further steepen the cornea. Now coming to the AC depth, you can see that it is very shallow, 2.65, whereas you need at least a 2.77 or 2.8 to do an intraocular lens. So this may be a patient who is suitable for neither. And in such a circumstance, depending on the expectations of the patient, you may think about doing a refractive lens exchange, which may be a better option for this patient. Now, if you consider this patient, you can see that he has a moderate refractive error to the tune of -6 diopters, and a very good pachy of 591 microns, and a very shallow, anterior chamber depth of 2.31. So now if you look at the cornea, it has an average pachymetry of around 41 diopters, and such a patient, when you do a -6 correction, will go to somewhere like 34, 35. So anything beyond 36 or 35 makes the aberrations magnify, and so laser vision correction might not be an option in this patient with flat cornea, though he has a good pachymetry. On the other hand, if you want to go for a phakic IOL, the chamber is too shallow to take that IOL, so it may be a good idea not to go for a phakic IOL either. So these are the patients where you have to look into each and every aspect before you zero in on a particular treatment. You also may have, it's not compulsory, but you also may map the epithelium, and sometimes, there are some clues as to very, very early ectasias when you check the epithelium. And of course, I believe that endothelium, whether you're doing laser vision correction or an ICL, is very, very important. So the dictum is that the refraction has to be stable. Whatever correction you're doing, whichever modality, and always try to, pick up small markers that may be present in the patient profile. So here you have a young patient with a relatively normal kind of refraction. He had an earlier history of unstable refraction. Now, he has been stable for the past 8 months, and you can see that there's something abnormal about the refraction there. The eye which has a higher error seems to have very good vision, whereas the eye with the lower error has, a corrected vision which is quite low compared to the other one. So that's a bit paradoxical. Now you come to the maps and you see that there are indicators everywhere, whether it be the pachymetry or the anterior and posterior elevations or the steepest K. So you can see that all these parameters have some or the other red markers, which may not be very gross, but are subtle. So you can see that both the 3 and 5 mm zones have high irregularity. The thinnest pachy is less than what is suggested. The mean CCT is less, the max K is borderline, and there is gross inferior and superior asymmetry with elevation of the posterior floats. So in all these cases, especially with skewing and such, obvious topographies, this may be avoided. And then if you look at the other eye, you can see that it looks pretty normal. Everything is within the normal range, and that's when you realize that keratoconus is an asymmetric disease. Even if you have a completely normal topo in one eye, you have to think of the presence of formae fructae keratoconus in the other eye, and that patient better be avoided. So the condition that needs to be treated here is keratoconus and not refractive error. So you go in for a format like C3R before you go in for a maybe another procedure like a phakic intraocular lens. Then of course patient counseling is very important, and you have to be very dot on, telling them beforehand what to expect, and afterwards how to continue with the medications, the precautions. So an ICL is a good option in a lot of patients that we have seen topographies of that cannot undergo laser vision correction, and that is basically because it is present very near the nodal point of the eye. It has a stable location far away from the endothelium. So here we are talking about a posterior phakic IOL, unlike the rigid anterior segment phakic IOLs that used to be there before. And the plate haptic design keeps it very stable. These are the optic parameters that we have. And of course, all the measurements need to be right. So the white to white, or whether you're going for the anterior chamber depth, it has to be very accurately measured. Then the lens is a pliable material. How you draw in, all that is very important to give good results. How you orient the lens, whether it's manually or using a Varion or any image guided system, is very important. Then once you insert the lens, the maneuvering should be minimal so as to prevent any form of pigment dispersion, especially while doing IA. And then these lenses can also be kept as piggyback lenses. Now this is a post-trauma eye with a high refractive error and a PCIOL in place. So the high refractive error can be corrected by keeping the ICL over the IOL. Just be sure that there's no residue in the interface. Then again, vaulting, I think, will be talked about during the complications. So these are how you divide between laser vision correction and phakic IOLs.